Why
It is a
that is
small step.
important?
It is a small step, but it goes a long way to make the surgery quite feasible because this
Yeah.
is a limited access surgery. So
Yes, sir.
these
Yeah.
small steps goes a long way to actually give you a good visualization. Then next what?
Right.
Now two stay sutures are taken on the bladder surface, and the bladder is incised vertically. We put a stay suture on the lower end of the vertical incision so that the incision does not further extend downwards beyond what we have made.
So the stay sutures that you have taken initially are on the surface of the bladder. Once you've opened it, you will need to take full thickness stays. Otherwise, they will sort of,
cut through.
yeah, you won't have good grip on the wall because the
Okay.
initial one would be just outside.
Yes.
Right.
Then Dennis Brown retractor is placed and the retractors are applied and two gauze pieces are kept so that to push the bladder up and lift the trigone into the field, sir.
So you want to put the blades into the bladder or somewhere else? The Dennis Brown blade, what do you do?
It is means the circular plate is kept on the abdominal wall and it is kept on the gauze piece and pushed the muscles, sir.
No, I'm talking about the 4 retractors, the Dennis Browns. Are you putting them on the rectus or are you putting them into the bladder? Some people put it into the bladder.
Into the bladder surface on the supported by the gauze pads.
You have a ring retractor which can do better for a bladder. There is also slightly more bulkier for smaller children.
Okay, sir.
See,
yes, some people do it. Some people because it removes the need for an assistant. You can do it without assistant if you put it inside the bladder.
Yeah, you mentioned the Dennis Brown ring retractor. No, we are talking about that only.
So inside the bladder.
Okay, so if you are going to put it inside the bladder, yes, some people do it. But remember that can be quite harsh on the bladder and it can be vigorous on the bladder. It can cause a lot of whatever surface mucosal injury, and it can make your dissection of the tunnel also difficult because the bladder gets immobilized and the pliability is lost. So those who put the thing into the bladder to retract, these are the problems you have to deal with. Otherwise, the general thing is that you retract the 2 recti on both sides.
Okay, sir.
And don't put it into the bladder. And then superiorly, you have the deaver, whatever, with your gauze piece to retract the fundus of the bladder. And below, you have a stitch, and you might put a retractor below also. Because there are 4 retractors.
Okay, sir.
So remember that. So both ways are fine. You have to justify what you want to do and what the pros and cons.
Yes, sir. Next, you identify the ureteric orifice plan for reimplantation, sir. You can pass a 5 French or 6 French IFT into the ureteric orifice and take a stay stitch using a 50 or 60 vicryl to fix the ureteric orifice to the infant feeding tube. Then
60, yeah, 60 is very, very thin. So 50 is okay because 60 might be very thin. Okay.
Okay.
You should say what you do. 60 snaps also. So
50.
Yeah, so 50, yes. Maybe in an older child, you might take a slightly thicker one suture also. You might even take 40, depending on the age. So all these figures, no, 2 centimeter above the thing, and this is all age dependent. So generally, those are the ones. Yeah.
Okay. Now mobilization of the ureter. If it's a unilateral ureteric mobilization, only that ureter is being mobilized. But if it's a bilateral coherence,
no. But how is that mobilization done?
Sir.
You have taken the stay suture. Where have you taken the stay suture?
On the ureteric orifice to the infant feeding tube, sir.
Okay. So you want to take 1 or you want to take 2?
So one.
What do you do? You take 1. Okay, fine, no problem. There are some people who will take on the medial side and on the lateral side, and they will take a different suture so that later when they tunnel it, the twist will not be there and so on. So that also is fine. One side they will take a catgut, one side silk, and so that the twist will not happen when they're done. You want to take on one side, it's fine. But remember that the orientation should not change.
Yes.
Fine. Then
using a needle tip monopolar diathermy, I would like to mobilize a terminal 2 centimeters of the plant ureter circumferentially and then create a dissect more on the inferior side to dissect a plane between the bladder musculature and the urethra, strictly reaching to the outside the ureteric adventitia so that I don't disrupt the blood supply of the urethra. And once I reach little more laterally, using a blunt dissection, using a small peanut swab, I tease the peritoneum outside away. And at this point, I should make sure that I do not injure the vas deferens, which may.
Before you reach there, you have marked the ureter all around the orifice with
Yes, sir.
fine tip cautery. You are saying you mark that, and that is where you are going to incise. You are going to use a low current. It's important, a very low current,
10 to
because you
15
don't
current.
want to burn.
Yes,
So you
sir.
will use that, and after that you have to enter into a particular plane. Which is that plane that you have to enter in so that you can do the rest of your dissection. You will go all around. Then you have to enter into a particular plane around the ureter.
So
So which
between
is that plane?
periadventitial plane between the.
Yeah. It's a periadventitial plane, and it is filled normally with loose areolar tissue. It is an avascular plane also. So
Yes,
it's a very beautiful plane. You must identify the correct plane. Otherwise, it will be all bloody, stained and everything. So it's a periadventitial plane. You are not going to disturb the adventitia because it is there that the vessels run. It is
Yes,
there
sir.
that the vessels run. Okay.
In between the
So
urethra
that's
and the vessels, sir.
correct.
After that, the peritoneum is swept away, and we should make sure that we should not dissection go beyond to injure the vas deferens, which might be in close proximity at this place. Once the ureter is mobilized for adequate length, then you close the bladder musculature so that lower end is closed so that.
So I thought you were saying only 2 centimeter you will mobilize. Now you are saying adequate length.
Sir, we should, for the adequate submucous, how much tunneling length we have to Packin's ratio, you have to see, and that much length of ureter should be mobilized so that it can come tension free to the neo-ureteric site on the opposite side, sir.
Suppose the ureter is very dilated, 2 centimeter. That means you can't make a 8 centimeter tunnel, no? What are you going to do?
So in that case, we can taper the ureter, what we are planning to do.
Fine. So generally, you have to.
What is the way you taper?
So either we can do excisional tapering or Klasinski's pinch and fold tapering, sir. Or you can do an imbrication kind of tapering also, sir. One we have seen is an excision kind of tapering where we put excise the extra length and taper it over on top of a infant feeding tube, sir.
What infant feeding tube?
Sir, 6 French only, sir.
Then you will get proper ureteral stenosis. The tapering is always done over a fat feeding tube, okay, so that you don't narrow it too much. But remember that we are trying to narrow the ureter to approximately a centimeter diameter, so that we can have a tunnel which is around 4 centimeter, 5 centimeter max. You really can't have a tunnel much larger than that. So you must have a proper size tube, at least a 10 tube there, and you can taper around it so that you don't end up having a too narrow a ureter. So whether you do this tapering here or you do a reverse gastric tube tapering for esophageal replacement, everywhere we keep a good caliber tube because we don't want a narrowing, right? Yes. And the other thing is, which side will you do the tapering? In other words, how will you choose the surface on which you will do the tapering? Which side? What are you looking at?
See, away from the vasculature. Away from the vasculature.
Exactly. Okay, fine. So now, just to ask you further on that, from which side does the vascular supply come in the lower part of the ureter? From the medial side or the lateral side?
Medial sides. 3 and 9 o'clock, sir.
No. The upper part of the ureter gets its supply from the medial thing because the renal vessels, etc., etc. The lower part of the ureter gets its supply from the lateral side, the pelvic part of the ureter, because there it comes from the inferior vesicle, the common iliac, and further down from the uterines and all in the female. So it's on the lateral side. Remember that. So when you do a pyeloplasty, the way to remember it is when you do a pyeloplasty, you do your spatulation on the lateral side.
Yes, sir. We take a
remember
beat
that. Okay.
slightly the lateral side.
Okay.
Uh, the new ureteric
So
orifice.
when you are
Sir?
now the peri-adventitial plane, so do you also take stay sutures on the bladder mucosa to retract it, or it's not required? You have taken a stay suture with the feeding.
Sir.
Do you also need to take 4 stay sutures on the bladder or also mucosa to retract it, or you do it with a forceps?
So by traction on the ureter and then forceps.
Okay. So you don't take on the bladder mucosa. Fine. So you say what you do.
Okay.
Okay.
The new ureteric orifice is planned on the.
What instrument do you use for your blunt dissection? You said no. So do you use a sharp scissor? Do you use a blunt scissor? What do you use?
Reynolds is supposed to be used.
Yeah, I know. But do you use that?
No, sir.
Okay, fine. Okay, a blunt scissor
Blunt.
is used so that you don't damage the vessels. Basically, you want to sweep. Okay. Cut and sweep, cut and sweep. You can use fine cautery to buzz, but that cautery must be
Dorset current.
far from the ureter.
Okay, sir.
It should be far from the ureter. Right. So the vascularity is not compromised. Okay. So you have to mobilize. How do you know you've mobilized enough? That's what he was asking.
So when it can come tension free to the opposite ureteric orifice, opposite to the planned ureteric side, when it can, when you take
to the planned new
and it
ureteric.
does not retract back.
So in your tunnel, so that long it must be so that it does not retract back. Okay. Go
Now,
ahead.
the bladder mucosa above the other ureteric side is gently elevated with the forceps and incision is made, and the submucosal tunnel is made till the other end using a right angle forceps. And
so you first make the tenting of the thing and the thing on the opposite side, then you do the tunnel, is it?
yes, we lift the bladder
Achha.
mucosa and incise the bladder mucosa. Then
Achha.
enter in the submucosal plane, use a right angle forceps, and remove the IFT tube and holding the stay sutures, pull the ureter to this side, sir.
No, but you have not made the tunnel. The entire technique here is, besides ureteral dissection, how to make the tunnel. Let's say left ureter, you are doing a reimplantation. So tell us, you have mobilized the ureter. Now tell us how you are doing the tunnel.
You would make
How
the
do you
tunnel
do
with a
the-
right angled forceps. I think most of us do the tunneling with something other than
else.
a forceps.
Yeah. So tell us how you do the tunnel. It's very important that you should tell us how you do the tunnel. The submucosal tunnel, how do you do?
So lift the bladder mucosa, incise it, enter into the submucosal plane, and
Okay.
then
So you are
extend it.
doing the left side. You are doing the left ureteric reimplant. So are you going to do the left side there itself where you are mobilized? You will use a you will take stay sutures there on the mucosa, and then from the left to the right you will make the tunnel.
Okay, sir.
Right. You can incise on the right side your plan thing, whatever you are saying. So how do you make this tunnel? You've got the mucosal stitches. How do you make the tunnel?
Instrument.
What instrument do you use? What technique do you use to make the tunnel? Some words should come here.
I'm not sure, sir.
Okay. The instrument that is used, like you said, Reynolds there. So you can use a Reynolds. You can use some other blunt scissors also. They have to go in the submucosal plane between the detrusor and the mucosa. They have to push and snip, and sweep from one side to other, so that you have a wide tunnel for your ureter. And after you finish this full process from the left to the right side, you will come out on the right side.
Okay, sir.
Understand? So these words should be there, that you are in the correct plane, and you know that you are in the correct plane if it does not bleed.
Bleed.
Right, and you must it is submucosal plane. You can see the blade of your scissors through the thing. If it is a huge normal mucosa, not an inflamed mucosa, etc. And
Okay.
then push and snip, push and snip. Snip means cut. And your Reynolds scissors if you're using the Reynolds.
Okay,
And
sir.
extremely important is
So
that
just
it should be stretched well. If it is
Ah.
not stretched well, then it is not. Suppose your mucosa just gets torn in the between while tunneling, which will happen in the beginning years. So what will you do?
So I can resuture using an absorbable 50 Vicryl or a chromic advent.
Yes. Right.
Yeah, so you can repair that, you can continue, or you can go to that area where the mucosal rent has happened. You can continue tunneling from there, or you can continue tunneling from where you have started, but repair.
The mucosal.
So it may sometimes happen.
Yes. Yes.
Yeah, you can do that.
And in fact, there are some peers, there's also a variation of the procedure where they open up the entire mucosa, put the ureter and then close the mucosa over that. So it is all right if you open up somewhere and you can close it. But this, and how do you know you are in the right plane? I
So
just told you.
the dissecting instrument will be seen under the mucosa.
Yeah, and bleeding will not be there.
Bleeding will not be there. Yes.
If you violate into the muscle, then you will get a bleeding.
Okay.
Right? Okay. So you've done the tunnel. Now, how do you channelize it? And what are you careful about when you channelize it from the left to the right?
I'll remove the IFT and then using the stay sutures only without causing any tilt or twist to the rotation of the ureter, I will pull it towards the neoureteric orifice.
Okay. Fine.
Here,
So
sir
you
has
have done
already
that?
told you, and you must make sure that there is no twist, because that is going to ruin a very perfectly planned surgery. The ureter should not be twisted.
Yes, sir.
How will you make sure that Sujay is asking? You have to make sure that there is no twist. You have taken it across. You think there is no twist. You have taken one stay suture. I will take two, median and lateral. But after that, how do you make sure that it is not twisted inside? What can you do on table to make sure that it is not twisted inside?
Something
What
simple.
do you do on table? You must have seen. Any tube, to make sure there is no twist, what do? We cannulate it.
Cannulate, sir. Okay.
Yeah, so you just put in the feeding tube, very smoothly it should go.
Put an IFT tube again, sir.
Correct. So these are simple things, but they tell the examiner that you know how to do the procedure. So after we've channeled it out, you put in a feeding tube. See that it maneuvers well, right?
Okay, sir.
Okay. Then what do you do?
Then excise the terminal portion which you have mobilized and then spatulate it and suture it to the end of the mucosal opening using a 50 Vicryl or 50 PDS.
It will slip out. You didn't tell us a very important procedure step. You've not fixed the ureter. You are only fixing it to the mucosa now. You don't fix it anywhere else?
Sir, at the previous ureteric hiatus should be tightened.
That you will narrow. The previous ureteric hiatus will come to. So that you will narrow, I know. But this ureter needs to be fixed, no? Or you only rely on the mucosal fixation. You don't fix it to the detrusor anywhere?
Take a deeper, while you're taking that, you take a deeper bite also to the fixed underlying musculature, sir. The ureter.
Okay. Fine. Most of us actually take one suture from the ureter at 5 o'clock position in the face of the clock. So from the ureter to the detrusor, we take one suture, seromuscular suture, which fixes the ureter to the detrusor. And then we suture the full thickness to the mucosa all around.
Yes.
Right. So that is the only anchoring suture which actually keeps it. Nowhere else are you going to take any other anchoring suture.
Okay, sir.
This is the only anchoring suture which is taken a little proximal to the lumen on the wall of the ureter. Okay, then you have spatulated and you are doing it all around. Okay. How do you narrow the hiatus? You were telling us something about the hiatus.
By closing the detrusor muscle around the ureteric opening, previous ureteric hiatus to prevent a further diverticulum formation.
So how do you know
what
that
precaution to take when you
are? So we should make sure that we not take too deeper beyond the detrusor muscle to prevent injury to the vas deferens and.
No, that is not the point. You are not going to go really so much. You've swept it off. So vast will be swept off with that. You're careful about that, I know. But how do you know that you're not made it too tight? That is what we want to know.
Before that only, I'll put a DJ stent through the urethra.
DJ stent is such a thin stent. You think it's going to assure you that you haven't narrowed it. Otherwise, you'll have a new VUJ obstruction you are creating at the hiatus.
So the previous existing IFT tube also will prevent too much tight at
Okay.
the area. No, sir.
Okay, that is also number 6. Let me tell you, generally what we do is, when we do this, we can take 1 or 2 interrupted sutures to narrow the hiatus. We always put in a right angle there, a good size right angle, to make sure that we have now not narrowed it too much. If this is where we are closing, we have closed 1 here, 1 here. So we put a right angle here to make sure that the tip of the right angle goes in freely there
Okay, sir.
between the ureter and the thing, so that it is not narrowed too much. We don't want to create an obstruction at the neo hiatus.
Yes, sir.
Right? Okay.
When you are making the
and-
anastomosis between the ureter and the bladder, what precaution is to be taken?
Yes.
It has to include the mucosa to mucosa. It has to take a bite from both the bladder mucosa and the ureteric mucosa.
Full thickness mucosal bites.
Yes, yes. Mucosa is very must.
Yes, sir.
You
The
must have the mucosa of both, and like you said, the full thickness of the ureter.
Yes, sir.
Right? Okay. And spatulation, you said.
Yes.
Right. And your tube also must negotiate now properly, so that there is no kinking in the tunnel, there is no kinking at the hiatus.
Yes, sir.
So your tube must go in and come out. Then
Come
you can change it to your DJ or
Okay.
whatever you want. Okay.
Suppose
Continue.
suppose you work in a center where you do not have DJ stent. Would you do a stentless
Yes.
surgery or you would improvise?
What will you do?
Which is not available every place. You may even have a problem of size.
So you can put a ureteric catheter also, sir. Through the
Okay. What
So-
else?
So,
Simpler.
so DJ stent is not available. So ureteric catheter also won't be available in those basic centers.
Yeah.
bring out the IFT along with the SPC, sir.
Correct. Correct. You can use an IFT when we didn't have
Very nice.
earlier.
So
we were
you can
using the
very
IFT.
nicely use. We have been So sir has also
Yes.
used it. I has also used it. There was no DJ stent. We were using IFT. It used to come out
Yeah.
through another incision and
Correct.
very
Some
nice.
of your friends have said in the chat box, you can use the IFT itself. Okay. Okay. Fine. So you put the stent, you would have finished this.
Hemostasis is secured, gauze pack is removed, and or either you can do an SPC or leave the Foley's in situ for the drainage and allow the bladder to heal.
Okay.
Bladder is closed in 2 layers, and muscle is closed, and skin and subcutaneous are closed, sir.
Where's the
Do
drain?
you put
we
an
can-
SPC in all cases?
We have to put an extraperitoneal drain, sir, along the bladder surface.
SPC in all cases? Foley's catheter SPC in all cases?
No, sir. We just use a Foley's catheter only, sir. But
Okay. You
SPC is
don't use an SPC.
SPC is an additional security to allow for bladder healing, sir.
Yeah, fine. Some of us use only SPC. We use only SPC. We don't put the Foley's. So you can choose whatever you want to use. You must have good bladder drainage for the bladder to heal.
Yes.
That is the final thing. And the perivesical drain, don't forget.
Yes.
Okay.
And at the finish of your surgery, very nicely said, please tell me why it is known as a transtrigonal.
When your tunnel is supratrigonal.
It's a cross trigonal because you're taking the ureter to this side and bilateral, left goes to right and right goes to left. So it's a cross trigonal.
So finally, if you are doing bilateral, it is one of the tunnels actually which actually comes in the upper part of the trigone, and the other one goes a little above.
Yes, sir.
It's okay, but semantics, but it is known as cross trigonal. That's all right.
Yes.
Fine. So suppose you had to do bilateral, and one side ureter is 2 centimeter, other side ureter is 1 centimeter. So where will you do the better tunnel? The better tunnel is always the one which is in the trigone, isn't it?
The most lateral most should go above the other ones.
What is your other consideration? Just use your rationale to tell me you will favor which ureter to give it a better backing in the in the trigone when you do the thing.
The lower diameter ones.
Yeah. So the lower diameter one, invariably that side will have better
Kidney
function also. So actually you're looking at the renal function rather than anything else.
We are
So
trying
the
to
better
preserve the
kidney,
kidney.
you are going to give the best
Kidney
chance.
better function should be preserved more than the other kidney.
Yeah, that's thing. The better one should be preserved. Okay, so if this is just, you have to justify these things when you say that is right. Post-op care,
So bladder drainage will be continued for at least 14 to 15 days. Antibiotics, IV fluid should be given.
14-15 days. Do you? You normally keep so long, bladder catheter.
Yes, sir. For
Acha.
at least 7 days should be given.
5 to 7 days I can understand.
5 to 7 days.
Yeah, 5 to 7
Urothelium
days.
heals. Remember that urothelium heals is one of the fastest healing mucosa.
Okay, sir.
When do you keep for 10 days, let's say? 14 is too much. 10 days you might keep for some situation. Which situation? You discussed that also.
When the incision has gone up to the bladder neck, so
If you are using stents which are coming out, then those stents are kept for 10 days. But if you're using a DJ stent, then it doesn't matter. Again, the bladder closure is fine by 5 to 7 days.
okay.
But earlier we used to use those stents which come out, the IFTs, etc. There, if you've done ureteric tapering, etc., there we used to keep for 10 days, those stents. But otherwise, by 5 to 7 days, everything is sort of over. Everything is out, right? Okay. Suja, anything else?
No, sir, I think everything is covered now. Bilateral also you have asked. I think everything is okay.
Okay, fine. So all these
Any role of
little
propan you would give?
This ureteric stent can cause bladder irritation and spasms. So we have to give postoperatively oxybutynin to reduce bladder spasms and pains.
Okay,
So, okay,
right.
all done.
I think we have one more person who will do cyst trunk. Yeah, Keshav.
Yes, sir. Good evening, sir.
Yes, Keshav. Cyst trunk.
Yes, sir. So cyst trunk procedure is done for thyroglossal cysts. So indications include all thyroglossal cysts, once diagnosed, have to undergo cyst trunk procedure. We'll avoid surgery when there is active infection, and only once the infection is treated, we'll go ahead with the surgery. Position is supine with the neck slightly hyperextended, and incision under general anesthesia, preferably with the ET tube rather than LMA. So incision will be a horizontal incision over the cyst, as much as possible on the skin crease. The width of the incision usually as much as the width of the cyst. Sometimes may be extended a little bit if required for mobilization. So we'll incise the skin, subcutaneous tissue platysma, and the layer of the deep fascia, and split the strap muscles to identify the cyst. And
after you've incised skin and platysma, you make a myocutaneous flap with the platysma,
yes,
and then you take stays down and up.
Up to
yeah,
for
right.
Retraction of the skin flap.
Okay.
And we'll dissect the cyst all around, and once we then we identify the hyoid bone. The superior
before you reach the cyst, there is something else you have to incise.
Fascia,
before you reach the cyst.
Deep fascia.
Yeah, the fascia between the two muscles. Which muscle is right there in front here? Sternohyoid. That. Sternohyoid. Yes. Okay. You have to incise the thing on the sternohyoid midline fascia to reach it, right? Then
we'll split the fibers or divide the fibers at the hyoid itself to mobilize the strap muscles. Once we reach the hyoid, we have to define the where we excise the part of the hyoid. So inferiorly, we'll divide the attachments of the sternohyoid muscles, and superiorly mylohyoid. And
but where do you do it? Where do you do this division of the muscles from the hyoid? In the midline?
No, sir. Just lateral to medial, just medial to the lesser
Paramedial.
corner.
You do it a little to the side because if there is a track in the midline, you don't want to take off, leave behind that track. You want to take the entire core, right from the infrahyoid till the hyoid and the base of tongue. So that's why it is a little paramedial.
Yes.
Okay.
And we should not go lateral to the lesser corner to prevent injury to the nose.
Yeah. So that is the thing. How do you know that you are not too close to the larynx? Because that is one thing that you have to protect from. What are your landmarks in the beginning of the dissection?
Cricoid and thyroid cartilages can be.
Cricoid, no. It is the thyroid notch. Thyroid notch. From the thyroid notch to the hyoid is the thyrohyoid membrane. That is what you want to avoid. Making a hole into the thyrohyoid membrane. So you know where the thyroid notch is and you stay well above that as you dissect up. Okay, because most of your cysts are infrahyoid, remember, 60-70%, whatever. So that is the area where you must lift it up from the thyrohyoid membrane so that you don't make a hole there into the larynx. Right. So how do you dissect that hyoid next?
So once we mobilize the muscle attachments and freed the hyoid, we have to cut the hyoid bones on both sides.
No, but you have not dissected the hyoid yet.
Yes, superiorly will divide the attachments, the mylohyoid and
the hyoid is still connected to the strap muscles. Now, sir is asking how do you just can't cut it. You have to free it.
Yes. Superiorly mylohyoid and hyoglossus, sir. Inferiorly stylohyoid. I mean, sternohyoid will release. Then we'll cut in small children. You can use quarter itself.
So you have to reach the periosteum, right? So on both sides, paramedian, you've taken off the muscles from top and bottom. You have to that area is bare. So you reach the periosteum. Very important to bear it properly. Now, how do you go around it? Because your cutting or whatever will be once you've gone around it and lifted it up from the larynx. So how do you do that?
Can use a right angle forceps.
Yeah. So find the thing, find right angle forceps, stay close to the periosteum, go behind that and hook it up. Make space there for your whatever you want to cut. Then you can cut that on one side. Then on the other side. Then only you can reflect it upwards to dissect the posterior part. Otherwise, you can't see the posterior part. Either you reflect from one side or you reflect cranially after doing both sides. So if you say all this, then the examiner will know that you actually know how to protect the larynx behind. Because you must protect that thyrohyoid membrane. You can't make a hole there. How do you do that dissection? The larynx part, dropping it down the thyrohyoid membrane. How do you do that dissection?
Blunt dissection, sir.
Blunt dissection with a pledget. A blunt dissection staying close to the periosteum of the hyoid posteriorly. So you drop down the larynx, the thyrohyoid membrane. And then you lift it up. Next.
Then because we don't try to identify the duct and stay close duct, we take a wide bit of tissue directed towards the foramen cecum. You can use the assistant or anesthetist can put a finger on the oral cavity and press the foramen cecum down to identify where we have to go.
What is the direction? What is the direction of your dissection here?
Upwards and backwards. Upwards and posterior.
Upwards and posterior.
Posteriorly.
Yeah, it is not towards mentum. It is little deeper, posteriorly. Yeah, and you said something that you have to remain medial to the lesser cornu. That's right. There is another landmark, muscle landmark, which is important so that you don't go too laterally. Because if you go laterally, you can damage something. That you will tell me later. So what is that other muscle landmark which can be seen there?
Sorry, sir, I couldn't get you, sir.
Which muscle? Which muscle? You have to stay medial to that muscle also. Just like you said, you have to stay medial to the lesser cornu. So which is that muscle? Which is here?
Digastric, sir.
Anterior belly of digastric.
Digastric.
So you have to remain medial to that. All this is so that you remain far away from something that you shouldn't damage. So what is that thing which you will damage if you go too lateral?
Hypoglossal nerve, sir.
Before that. Correct. Hypoglossal is also true. Before that, another nerve, the other nerve.
Lingual nerves.
Superior laryngeal. Yeah. So we don't want to damage the superior laryngeal. We certainly don't want to damage hypoglossal. These are the two nerves which can be a danger if you go too lateral. Okay. So remember sternohyoid, mylohyoid, superior laryngeal, hypoglossal. All these things you must remember. Okay. Fine. So you've dissected a core and you've gone.
Yes.
Go ahead.
Once we reach the base of tongue, we'll identify, we'll ligate it off with the either absorbable sutures, sir, and cut the tissue above it.
It is always not possible to reach the base of the tongue. Can you make it more accessible to your dissection field?
Yeah. How do you do that?
By putting the finger in the oral cavity and pushing the tongue down.
Yeah. And if your suddenly the whole tissue snaps, then what do you do?
I didn't get that.
I'm saying the assistant gave too much traction and the whole tissue snapped. You were tracing it rightly.
The track snaps. Very often it happens.
The track snaps.
What will you do?
We can dissect that tissue in that area. Central neck dissection. So
there are two ways out of it. One is that you leave everything and stop there. So another thing is you try to identify and carry on your dissection via the whatever remaining tissue is there. So what will you
do? Better to exercise whatever we can, sir, because chance of to treat recurrence is difficult.
And remember that you have already taken out, as you have gone ahead, you have already taken out the hyoid, one of the main centers, which is the cause of recurrence. So if you can easily identify the proximal part and the base of the tongue, you can identify, then you go ahead. Otherwise, you don't do undue harm to the tissues nearby.
Okay. Right. So you've ligated or you've stitched there, and then you've taken out the central core of muscle a little there. Then
we'll approximate the strap muscles, sir.
Okay, if you can get it approximated the sternohyoid, you do that. If the gap is too much, then you don't do. If you can do it, you do it. Yes, right. You'll have get the strap muscles. Then
we may keep a drain, sir, if anticipating any infection.
Normally you don't keep. It's safe always to keep a drain, but it's your choice. But generally, it is safe to keep a small drain, a Penrose or a glove or whatever, and then take it out in a day or two if everything is fine. And then closure.
Yes, it's subcutaneous closure and subcuticular.
Platysma
and subcuticular.
Okay, right. Fine. So you have said all the things correctly. Remember those important safety points which we discussed. Yes, Sujay, please.
I was asking antibiotic policy after this surgery.
We usually give only one dose of prophylactic antibiotic at the time of inductions.
Yeah, it's a clean surgery. We don't need one dose. Perioperative is okay.
Okay. So what was the Schlange procedure which was done earlier?
Yes, Schlange was the initial first person who identified this presence of thyroglossal duct extending into the hyoid and into foramen cecum, sir. But he used to dissect only the duct and proceeds, not take a rim of tissue around.
Not take the rim of tissue, yes. So that's why recurrence was more in that, and then okay, right, fine. I think we have covered everything. Any questions? That was a good description of the procedure. So all these things you must remember, all the keywords that the examiner wants to know, and the practical aspects of all these things. Must remember. And there's a question there: do we take stays on the bladder mucosa while creating a tunnel? This is what Sujay was asking. So, the bladder mucosa stay is taken so that you can hold it up and get into that space. It makes things easier. But if you think you're going to hold it with a thumb forceps and do it, it's fine. Forceps traumatize the mucosa. So if you hold it up with stays, it makes things easier. That is why we use stays
So the whole
wherever we have.
make the of dissection clear to the surgeon. So if it is okay without it, you can do it without it.
Yeah. Right. Yeah, someone has said recurrent laryngeal nerve. Well, recurrent laryngeal nerve area, we usually don't go. Yeah, superior laryngeal nerve is the one that is at danger, and hypoglossal is at danger if you are too lateral, because that is where they course and go up. So those are the
Different
two
laryngeal
nerves
nerve
that
is a
are.
different force. The tracheo-esophageal groove. It is not going to come there.
Yeah, we are not going into that area. Right. Yeah, then there's the question, hematuria after ureteric reimplantation. It always happens, isn't it? In any bladder surgery, etc., especially if you've done reconstructions in the bladder, reimplantation, augmentation, etc., etc. So it will settle down after some time. So you just have to be patient with it, enough fluid so that it gets washed out, tubes shouldn't get blocked. And of course, you will manage the spasms with oxybutynin, midazolam, etc. So then it will settle down. And if there's an infection, of course, God forbid, that will cause more hematuria, but otherwise it should be okay. It will settle down. Yeah. Those are the questions there. Is it necessary to put Foley's till hematuria settles down? In fact, the best thing when you have hematuria in any reconstructive surgery is if you have an SPC, because an SPC is a wider tube and it doesn't get blocked. Particularly if you are using the old SPCs, which were those Malecos type of thing. They have large large holes and flowers, and it won't get things. The Foley's is the one which actually gets blocked. So an SPC is a very safe thing in reconstruction. But yes, if you're using Foley's, you need to flush it and keep it patent.
A lot of residents put Foley's in patients of hematuria. So I agree with sir that a Foley's is going to further narrow the lumen from where this hematuria could have come out. So there is more chances of clot with Foley's.
Yeah. Okay. I think the rest of the things are yes, rest of the things are taken care of. Any other questions? Otherwise, we will wind up. It was good discussion for both.
Another question says, for ureteric fixation, you said seromuscular suture at 5 o'clock. Any specific reason for 5 o'clock?
Yes. Yeah, I think that is the point that he missed, but that's an important step. But that is the only place we fix the ureter in ureteric incoherence. We don't fix the ureter anywhere else, unlike other techniques.
So that is the side where you do not split the line.
Yeah. Good. So we will wind up today, Sujay.
Yes, sir. Thank you so much. Sir.
Yeah, both of you presented well, and both of you clear. Bye. See you.